Thanks, Country. My name is Drew Ford. I'm an infectious diseases clinical pharmacist here at WVU Medicine. I presented a few times in these didactic sessions and prior echo sessions, so I'm excited to be joining again today. The theme for today's overall echo case series and didactic presentations are highly oral bioavailable antimicrobials. And so I actually wanted to talk about a an agent that is not highly bioavailable because I think it's good practice to understand why this antimicrobial that is still readily prescribed, mostly for typically non-severe infections, may not always be the best option in those cases. So tying a little bit of an antimicrobial stewardship consideration around this as well. So today we'll want to recognize the limitations and deficiencies of Cefdinir as an oral antimicrobial agent and be able to identify alternative oral antimicrobials to Cefdinir. As a little bit of background, Cefdinir is an oral third generation cephalosporin that was first approved for use in the United States by the FDA in 1997. A few of its labeled indications include community-acquired pneumonia, bronchitis, and sinusitis, as well as pharyngitis or tonsillitis and uncomplicated skin and skin structure infections. It's routinely been prescribed also for urinary tract infections since being on the market, and it's available as both oral capsule and oral suspension for administration. One of the big hangups, and we'll talk a little bit about it in a couple slides in terms of its utility as a good oral antimicrobial, is its low oral bioavailability. So that refers to the percent of the drug that is absorbed from the GI tract and into the bloodstream. And you can see that whether you're using the capsule formulation or an oral suspension, bioavailability ranges anywhere from 16 to 25%, and in pediatric patients is often even lower than that 16% cited with oral capsules and suspension amongst adults. So using a bit of a baseball analogy, we'll go through a couple of strikes, three strikes and you're out, Cefdinir, and why it may not be an adequate oral antimicrobial for commonly encountered infectious diseases. So the first of those is its limited antimicrobial activity. So we might think of it as a third generation cephalosporin being equivalent to several others within that class, but fortunately, it isn't always as active as other agents that we categorize as third gen cephalosporins, and certainly other beta lactams for that matter. Cefdinir has demonstrated that resistance to strep pneumo, in its case, can exceed 20 to 50%, depending on what study you're looking at. And given one of its labeled indications is upper respiratory infection, like community-acquired pneumonia or pharyngitis, this is quite concerning as strep pneumoniae is an organism often encountered or implicated in these infections. Additionally, for other respiratory organisms like Moraxella catarrhalis and Haemophilus influenzae, Cefdinir is less active than a number of other oral alternatives as well. One big thing that I do see from time to time in practice is assuming that ceftriaxone susceptibility is equivalent to Cefdinir susceptibility for an organism whenever we're looking at a susceptibility report for a specific isolate. And that's not the case. Cefdinir should not be, or ceftriaxone should not be used as a surrogate marker for Cefdinir susceptibility when we've isolated an organism, whether that be from the respiratory tract or the urinary tract. And using ceftriaxone as a surrogate for Cefdinir often overestimates susceptibility to Cefdinir, often by 30 to 40%, depending on the organism that we're looking at. Notably, national guidelines for pneumonia, UTI, and sinusitis don't routinely recommend the use of Cefdinir for treatment. And in fact, a randomized controlled trial that was sponsored by the manufacturer of Cefdinir itself in comparing its use to amoxicillin clavulanate or Augmentin for community-acquired pneumonia found it inferior to Augmentin in terms of clinical cure and bacterial eradication. So for all these reasons, we recognize that Cefdinir doesn't have as great antimicrobial activity as a number of alternatives that we'll look at in a couple slides. Beyond its lax antimicrobial activity, it suffers from a number of poor pharmacokinetic and pharmacodynamic instances that make it even less likely to be successful in treating an infection. Notably, Cefdinir is highly protein bound and often reaches suboptimal pulmonary and urinary concentrations. This will be illustrated in a couple slides, as I've alluded to, but often these concentrations are below what we'd want to obtain if treating an infection in those particular spaces. The predominant pharmacokinetic parameter that we want to consider when using a beta-lactam is the time spent above the minimum inhibitory concentration of a bacterial isolate. And a 300 milligram dose of Cefdinir only achieves time above MIC of around 10% when considering an MIC of 0.5. Now, the MIC could vary depending on what organism you're targeting, but generally speaking, for most bacterial isolates, we're going to want to target an MIC of at least a time above MIC of at least 50%. So you can see that Cefdinir comes in quite below that target, even when using its labeled dose. It also has a short half-life, which kind of explains why that time above MIC is so low, in addition to its high. It's often highly bound by protein and just doesn't concentrate in certain sites very well. Lastly, third generation cephalosporins like Cefdinir are an antimicrobial stewardship burden. So Cefdinir, along with other third gen cephalosporins that I'm not talking about today, can increase the risk of colonization of things like vancomycin resistant enterococci, extended spectrum beta lactamase, and AMP-C expression amongst Enterobacterales. Third gen cephalosporins, depending on what piece of literature you're looking at, are often attributed to the development of C. diff infection, sometimes as the highest ranking class amongst all antimicrobials, again, depending on the source you're citing. And this is important because antimicrobial resistance is actually expected to surpass both cancer and heart disease as the leading cause of mortality worldwide by the year 2050. So doing everything we can to avoid the development of antimicrobial resistance. One of those ways is to reduce the prescription or use of third generation cephalosporins. Is a great way to hopefully curb this trend we're seeing. So what are some alternatives to Cefdinir? This is a good table that looks at both oral bioavailability, lung and genitourinary tract penetration, and percent susceptibility to both Streptococcus pneumoniae and Haemophilus influenzae, common organisms that we see in upper respiratory tract infections. You can see pretty much every beta-lactam alternative I've listed on this table has greater oral bioavailability than Cefdinir. That's the case as well for penetration into the genitourinary tract. So all of these options are probably better for UTI. And it has worse lung penetration in the epithelial lining of the lung tissue than other beta-lactam antimicrobials. I alluded to it earlier, but Cefdinir is routinely resistant, excuse me, strep pneumo is routinely resistant to Cefdinir, and that percent resistance, like I said, can vary. The percentage cited here is only 59% susceptible from this particular study. And it also doesn't have as much activity against H. flu as other orally orally administered beta-lactams. So for all those reasons, we have quite a list of agents that would be probably better used in place of Cefdinir. One thing I wanted to highlight is here at our institution at WVU Medicine, it's a health system encompassing hospitals in West Virginia and neighboring states, including Ohio, Maryland, and Pennsylvania. We recently removed Cefdinir from our hospital formulary. Due to all of the factors that I mentioned in the previous slides. So this is just an example of an EduBlast graphic that we had sent out as education on the formulary removal of Cefdinir, illustrating opportunities for using alternatives like amoxicillin clavulanate or cefuroxime in the case of community-acquired pneumonia, or things like Keflex, cephalexin, or cefpitoxime in urinary tract infection. So I wanted to pose the audience a question. Do you routinely prescribe or recommend Cefdinir in your practice? And then yes, and if yes, what clinical scenarios do you use it in? For all the reasons I mentioned earlier, a lot of what we focus on in these didactic and case presentations is treatment of deep-seated infections with oral antimicrobials. So I kind of think of it as if Cefdinir is not cutting the mustard per se with our simple bacterial infections. It's definitely not a great option for deep-seated um, bacterial infections in which we're using longer courses of oral antimicrobial therapy. See Jacob answer, nope. Good. Good, yeah, a lot of good alternatives. I think a big thing that I've seen, a lot of insurance companies list Cefdinir as a preferred third generation cephalosporin, and so sometimes when we're using or prescribing alternatives such as cefpodoxime, occasionally we'll get some pushback of it not being a preferred agent. I've not seen that as much in recent years, so I think that's often what may lead to its use or prescription. But feel free, anyone on the call today, to use this as a tool. If you see Cefdinir come up in your practice, just understand we have a lot of alternatives out there that are pretty much in every way better than oral Cefdinir. So that's all I have for you all today. Appreciate participation and messages in the chat. Feel free to send me any questions or speak up, and I'd be happy to answer them. But thanks again for allowing me to present.